As whole blood flows along in the fenestrated capillary, so kind of like in this area here, small substances like ions of sodium and potassium, they are all leaving the fenestrated capillary, fitting through the holes, and then fitting through the filtration slits of the podocytes that are blue on this picture. This would allow these cations to enter into the fluid in Bowman's capsule, which is all of this area right here between these simple squamous cells and the blue podocytes. These ions move into the filtrate that's formed from filtration, not urine, but filtrate. Any substances that are larger than albumin will remain in the blood capillary and will not be filtered out into the capsular space. And remember that this here is an afferent arteriole, whereas this one up here is called an efferent arteriole. Of course, your red blood cells and white blood cells, those are larger than albumin. They are too large to be filtered out of your whole blood. And this is why red blood cells and white blood cells are abnormal when found in urine, right? I mean, yeah, they should not be in urine. And if they are, it indicates a breakdown of this filtration membrane. Anything larger than albumin should also remain in your whole blood. But there are proteins that are smaller than albumin, and those are not abnormal to be seen in urine. Most non-polar hormones or steroid-based hormones are metabolized in the liver using their waste components to make bile. But some polar hormones, such as epinephrine, are metabolized in the kidney. And this means that they're removed by the kidney, which also indicates that these proteins, like epinephrine, are smaller than albumin. And they're capable of fitting through the fenestrations of the capillary, the podocyte slits, and entering into the capsular space. Therefore, small hormones are expected to be present in the urine. Cations and anions will always be filtered into the filtrate by the glomerulus. But you have to remember, there will be adjustments that are made in the second capillary bed. And those adjustments could remove some of these cations or anions or hormones from the filtrate, and that would render them absent in the urine. We have already discussed filtration when we talked about it way back with the blood vessels many lectures ago, many moons ago. Filtration is a process that moves items from a blood capillary and pushes them into the interstitial fluids. Here in the kidney, we still have that, but those interstitial fluids are the capsular space of the renal corpuscle. That space that is caught between the podocytes and the simple squamous parietal layer of the capsule. Blood in the glomerulus exerts a hydrostatic pressure, pushing things out of the glomerulus and into the capsular space. That hydrostatic pressure is the glomerulus hydrostatic pressure. It is not equal to your blood pressure, but it is largely determined by your blood pressure. On the venule side of a normal capillary bed, the colloid osmotic pressure of the blood would suck fluids from the interstitial space back into the capillary bed. That's not exactly true here in the renal corpuscle. We're not really moving anything, but maybe we're like preventing movement. There is a colloid osmotic pressure, or the attractiveness of solutes that are in the blood. This attractiveness tries to suck water back into the glomerulus, or at least prevent that water from leaving the glomerulus. The colloid osmotic pressure generated by your blood, how salty you are, how dehydrated you are, is a force that opposes filtration. So the blood colloid osmotic pressure keeps fluids in the glomerulus. Those colloids attract water. There is one more force or pressure that takes away from filtration or discourages it along with the blood colloid osmotic pressure. The fluid in the capsule actually pushes back on the glomerulus. So simply that fluid in the capsule pushes back. Think of the glomerulus like a water balloon submerged in water. The water inside the balloon exerts a force on the balloon wall. That's the glomerular hydrostatic pressure. But so does the water on the outside of the balloon. It also exerts a pressure on the balloon wall, and that is what is called the capsular hydrostatic pressure. These two things here discourage filtration. They would lower your GFR. This one thing here is the only thing that encourages filtration, and it's largely driven by your blood pressure. Net filtration pressure is a concept that we've seen before, although you may not have realized it when we did it then. Of course, this was in the blood vessels section. Remember, fluids are always leaving capillary beds by way of filtration, but not all of that fluid gets reabsorbed on the venule side of the capillary bed, right? And this excess was absorbed by your lymphatics. So in capillary beds in other parts of the body, as in other than kidneys, filtration is always greater than reabsorption, and that creates this net pressure that pushes or forces fluids and solutes out of a capillary more than it does reclaiming it into. And so this filtration pressure, we called this net filtration pressure, and we used values of hydrostatic pressures and colloid osmotic pressures to calculate it. Hydrostatic pressure, or HP, always stands for the hydrostatic pressure of a fluid pushing against, in our case, the capillary wall. Hydrostatic pressure is like the pressure that's exerted against the rubber of a water balloon. GHP is the hydrostatic pressure that is in the glomerulus. The blood in the glomerulus is pushing against the walls of the fenestrated capillary, forcing fluids from the glomerulus to the capsular space. This is the one and only force that encourages filtration. This hydrostatic pressure, the glomerular hydrostatic pressure, is largely determined by your blood pressure. So if you live in hypertension, your blood is pushing too much on the filtration membrane. If you live in hypotension, your blood isn't pushing enough on the filtration membrane. Either way, your kidney is not doing what it could be doing. We know that during surgery, our patient's blood pressure, our patient in the case study, our patient's blood pressure dropped dangerously low to about 30. And we usually want the glomerular hydrostatic pressure to be something like 60. So that's bad. Capsular hydrostatic pressure is the pressure of the filtrate that's in the capsular space. And just like the blood in the glomerulus has a hydrostatic pressure pushing fluids from it, the capsular space is pushing back against that. The capsular space's blood pressure is, the capsular space's fluid pressure is always less than that of the glomerular hydrostatic pressure. And this makes sense because the fluids in your capsular space are subjected to, or they're headed toward the renal basin. And that big open area in the kidney, it actually creates a pressure difference in the kidney, and it sucks the fluid through the nephrons. So if you have a kidney stone in your ureter, your renal basin has become clogged with urine wanting to get out into the ureter. And that clogging pushes back into the calyces and all the way back to the capsular spaces in all of your renal corpuscles of that kidney. And that hydrostatic pressure of the capsule goes sky high with a kidney stone. The last force that determines filtration is the glomerular colloid osmotic pressure. And this is basically the blood colloid osmotic pressure. Recall that colloid osmotic pressure is like the attractiveness that solutes have for water. BCOP, blood colloid osmotic pressure, specifically refers to the attractiveness of the solutes in your blood, or the ability of those solutes to keep the fluids in your whole blood and prevent it from filtering out into the capsular space. This value of BCOP varies proportionately with your osmolarity. How salty are you? Are you horribly dehydrated? If you're horribly dehydrated, then your BCOP, that should be 18, has probably risen to be about 28. Did you eat lots of salty crackers? Well, your BCOP went up. Did you pee out a lot of dilute urine? Your BCOP also went up. The significance of all of these pressures and calculating NFP lies in the relationship to the glomerular filtration rate, which is something that many of us have seen on a urinalysis. And luckily for us, the net filtration pressure rises and falls with the glomerular filtration rate. I encourage you to do these equations, right? Noting that this is a negative here, and see what numbers that you get and prove to yourself whether the net filtration pressure goes up or down. Many of us have seen our GFR tested, and this is the glomerular filtration rate, or how much filtrate is forming in the capsular spaces of all your nephrons in 1 minute. Of course, net filtration pressure will be a big determining factor of GFR. NFP, net filtration pressure, and GFR are proportionally related to each other. So this means that they rise and fall together. And this makes sense in the big picture. Net filtration pressure is the force pushing my blood through the filtration membranes of my nephrons. This is the force pushing filtrate into my capsular spaces, into all the PCTs, and all the way to the renal basin. In our case study, our patient's GFR dropped horrendously low in surgery. All of his little glomeruli deflated for like a split second, and his GFR dropped to essentially nothing. More than just the net filtration pressure or the ability to create pressure on the membrane determines GFR. The total surface area for your filtration membrane makes a big difference. For our patient, how many of his glomeruli were able to recover and reinflate and start filtering again? Not all of them, I can guarantee that. The next factor determining GFR is the permeability of the membrane. How healthy are your podocytes? Are the fenestrations in your glomeruli like blown wide open from a life of hypertension? Think about a strainer that you might use for like macaroni and cheese. If the holes in the strainer get bigger, some of your luscious macaroni might end up slipping through the holes. Not good. That's also what happens to your proteins, right? So you need the right size of fenestrations and filtration slits in your renal corpuscles. In our patient in the case study, his membranes they're just shot. Albumin and other proteins are abundant is in his urine. He's just peeing out his proteins, right? Because they're all now able to slip through the fenestrations in the capillary because they're blown wide open and through the filtration slits of the podocytes. His blood has hypoproteinemia, right? Because he's peeing out all of his proteins. There are other situations where people are peeing out proteins because of hyperproteinemia. That makes sense, right? Because if you fill a cup, it starts to overflow. And that's what happens with proteins. You might fill your value of protein in your blood and it starts to overflow into the urine. That's not what's going on in our patient. And we know that. We know that from other symptoms, from his history. We know that from knowing that his pressure dropped to nothing during surgery. We know that his fenestrations and his podocytes are not the right size.